Alrighty, welcome to the Ultrasound lecture series this week. Thank you guys for joining us, for being part of this lecture series. Today, I'm pretty excited. We have a friend of mine who's going to be presenting to us today. So Bob Stenberg is one of the ultrasound faculty over at the Cleveland Clinic Akron General facility, and he is a big ultrasound nerve block guy. He loves blocks. We talked about blocks when we were together at a conference recently, and I invited him to come talk to us about blocks, and looking forward to what he has to say and what he has to share with us about ultrasound guided blocks today. So Bob, take it away. We're looking forward to hearing what you have to say.
Thank you. So I am a huge block nerd, and based on prior content that's been covered at Metro, we're gonna try to supplement that. So to kind of do a big overview, and this is a little bit kind of fellow focused, kind of discuss a little bit how you would start building a nerve block program, and then we're kind of go through some nerve blocks, kind of supplement some of the prior ones discussed. So we kind of go through a few, and then based on how much time we have left, I'll try to dip into some other nerve blocks. So just gonna kind of go for it. I have no disclosures. While you're still awake and paying attention, here are some big take homes. So general block rules, soak the bear, don't poke the bear. When you're doing this with a resident or a student, just kind of keep on focusing and not losing the tip to kind of avoid any complications such as neuropraxia or vessel injection. Considering dexamethasone for pain blocks to extend the duration of the block. And then really kind of working on your pitch too, because I mean, you don't want to, falsely sell a patient something, but I think it's good to kind of have a sell. So that's kind of an example of a sell. And then kind of specifically for rectus medial blocks, which we're going to kind of cover upfront in detail, is kind of going for the corner of the transverse process. When you're doing this, you should not see the pleura, and we should do more of these. So we're going to kind of hit these points as along go the way, but kind of wanted to highlight them up front. So talking about block club, very similar to fight club. So there's those rules, kind of a bit of overlap. And I think one thing that's really great about these nerve blocks is that they benefit patients a lot and they have fun, but the rules, you also want to do this safely and also don't want to get sued. So you want to keep that in mind. So rule number one, you want to soak the bear, don't poke the bear. So you do not want to hit the nerve. You do not want to, inject directly into the nerve, because that's how you start getting complications. So if you want to completely ignore me for the rest of the time, this QR code is for watching this bear at a national park take a bath, which is pretty great. All right, so this is kind of examples of soaking the bear versus poking the bear. Functionally, every nerve block you should kind of think of as a fascial plane block, because your goal is to hit the fascial plane in which the nerve lies. So, if you're even peripheral ones are not traditionally thought of as a fascial plane block, you're still trying to aim for the fascial plane right next to it. So kind of keep that in mind as we're kind of moving forward. You always want to be thinking about having a safe dose. So this is out of Johns Hopkins, and it's an incredible app to use. And one really nice thing too is if ortho or trauma or someone else is doing a procedure preceding you, you can factor in how much they used and then see how much you can give safely. And it factors also in comorbidities and stuff. So this is a really great resource that you should use, and it's really fast and easy. Kind of one thing, especially doing high volume fascial plane blocks, it's always good to have something like that's quick and easy in your mind. And my quick and easy for fascial plane blocks is if they weigh over 110 pounds, they don't have severe cardiac or renal issues, you can very safely give 40 mLs of 0.25% bupivacaine, which is about 100 milligrams of bupivacaine. So I'll kind of ask a patient beforehand just to double check, do you weigh over 110 pounds? Do you have any serious cardiac issues? Do you have serious renal issues? And if not, a lot of times I'm kind of aiming for like 40 mLs of that 0.25 to hit that. You always want to follow your tip. This is one of my favorite images of a Capri Sun, where your ultrasound beam would be kind of your juice box and your needle is your straw, where your ultrasound is not following your tip, and then your tip is off somewhere in the body, poking something you don't want to poke. So keep that in mind. When you're doing, almost all of these blocks are really in plane blocks, so your needle is in plane of the ultrasound beam. And you really want to take, I always kind of tell people to really take the time to really line this up so you have better needle visualization. Continue on with visualization. We all know that we really want to have a good anchor with our hand for stability. And then some other kind of things that you don't always think about in this image, so this is the exact same patient and kind of exact same images, except there's an adjustment in the needle based on the angle. Which one is better in this image? If you look at the needle visualization, man, that left one is way better. Why is this better? It's because the angle is more perpendicular relative to your probe. The hard number, if you want to set in your mind, is you want that angle to be greater than 55 degrees with your needle relative to your probe ultrasound beams. So, sometimes in order to do this, sometimes it almost makes sense to even insert more distal, like away from your probe, so you can come in more flat. So that's something to keep in mind to kind of increase your needle visualization so you can feel more comfortable and feel like you're doing these more safely. What about this image? Kind of very similar scenario, same patient, same needle, but you can see now the right side is a lot different and you can see the needle a lot better in this image. What's the difference here? In this image, they're healing the probe. Sometimes you can't really insert, at a more shallow angle, but sometimes what you can do as an alternative is you can heal your probe. So then you're more perpendicular relative to your needle, even if you can't come in at a more shallow angle with your needle. So that's something else to keep in mind when you're trying to do these. To make sure that your block program always heads in the right direction, always consider confirming with making sure you're blocking the correct side. It's a little bit easier for us relative to anesthesia and other colleagues because we saw the patient's fracture, we examined them beforehand. We're not just walking into some random room and trying to do this, but it's always still good practice to make sure you're confirming the correct side. These are kind of like some different medications that people tend to use. Your long-acting anesthetic is really kind of bupivacaine or ropivacaine. If you have the luxury, ropivacaine is better because it has less cardiotoxicity. And then, some people even have some 2-chloroprocaine, like they use that at Highland, but, a lot of people don't have that. Getting a nerve block needle can be a great addition when you're trying to set up a program because it increases everyone's comfort so much because it, like these Padjunk Sonoplex needles, they machine the needles to increase needle visualization. They're blunt tipped and they have built-in tubing, so it kind of just makes everything easier. So if you can leap for this, I think this is worth the ask to your department to get these. If you don't have that, you can always leap towards one of these other things that you would use for a spinal epidural LP kind of thing. Another great addition in terms of adjuncts on top of the anesthetic, the most common one, the one that has the most evidence for it, is dexamethasone, and this is what I'll use a lot of the times. So you're going to add this with your anesthetic to extend the duration of that. It's probably best if you can use the preservative-free one because there's some theoretical, neurotoxicity if you use one that does not have preservative-free, but there's pretty robust evidence to demonstrate that adding dexamethasone to this will extend the duration of your block. So it's a great add for a pain control block. There's some kind of growing thoughts and evidence for clonidine, but I don't think we're quite there yet, frankly. When you think about this chart, what is this chart? You got someone confused and dizzy and they're having some tinnitus after getting the block. And then the next thing they're going into VT and they're arresting. So anytime you're setting up a nerve block program, you have to be ready to treat last. You have to have lipid emulsion in your department. And this is kind of one example of an algorithm about how to treat that. So you can stop seizures with a benzo. You're going to do a lot of ACLS things, but the other big pieces you're going to be using lipid emulsion. Again, kind of thoughtless numbers to put in your back pocket for quick kind of retrieval is your bolus in a standard adult patient is going to be about 100 mLs. And that's, by a ballpark weight base of about like a 70-kilo patient. And there's your subsequent bolus. So you also want, if you're doing a high volume fascia plane block, you also want to keep them on the monitor for a good half hour to make sure that there isn't any signs of last. When you're kind of developing a program as well, a lot of people, people want things that are fast and easy and convenient. And the more, if you're trying to push a program, the more fast, easy, convenient you can make it, the better. So this is an example of some nerve block kits that you can make. So providers are more easily just to grab that and go, and they're more likely to then kind of do that and push your program forward. Also, making a nerve block order set is another great add just for kind of ease and kind of making things smoother. Things that you want to consider, maybe I shouldn't do this block, is kind of a lot of things you would expect. You really, you want to be pretty mindful, make sure you're not blocking anything that could be developing compartment syndrome. So, if it's a calcaneus fracture or some other kind of thing, keep that in mind. The number of times that this has happened where you did a block and you're like, oh, is that going where it's going to go? This is also okay. This is part of it. And, the number of times that we've had, not pretty blocks that were still very successful was pretty high. So it's okay if it's not just immaculate block like you would see on YouTube or something like that. Another thing too is I think there's a little bit of patient selection component too, where some people, even though you perform a great block, some people it's just not going to meet their expectations, and because some people will have other secondary motives. So just keep that in mind and just kind of keep a little bit of a balance of your patient selection to make sure that the patient's satisfied and you're satisfied. So we're kind of starting to dip into cases now. So this was someone that came into RED. He was a fall off ladder, a bunch of posterior lateral rib fractures, small pneumo, and a little bit of some consolidation versus, contusion, et cetera, but posterior and lateral rib fractures. We go in, we do a serratus, which y'all have covered before. And what does the person say? My back still hurts. So, the serratus probably wasn't the best choice because of those posterior fractures as well. So now we're kind of move on to erector spinae blocks. And this is my recipe for erector spinae blocks. If you don't want to listen, there's my family's favorite Tater casserole recipe. But this is your simplified approach to doing these. And these blocks are absolutely exploding in the literature, and the indications are absolutely exploding as well into any kind of visceral coverage. It's also extending into even like treating headaches at the T4 level for, post-dural headaches. They're starting to explore it for different, extremity surgeries, such as knee surgeries and shoulder surgeries, on top of like innumerable different intra-abdominal, intrathoracic procedures. So I think this is going to be one of them that we're going to be doing a lot going forward because the indications are so profound. So kind of the way that you're going to think about these is you're going to do a pre-procedure, you're going to find your level, you're going to find your nubbin, you're going to lift the muscle off the nubbin, and then you're going to assess for improvement. So again, kind of working on your cell. If you tell someone that you're going to stick a needle in their back, they're probably going to freak out. So you need a cell. So one of the ways that I found that's been kind of a little bit of disarming is kind of explaining what you're actually doing is you're putting some medicine underneath the backstrap muscle to help with their pain. If you say that you're going to, stick a needle into someone's spine, they're probably going to freak out. But if you phrase it in this way, which is still not lying, I think it can be helpful. And then, I think this is also helpful for patients, but, also a good mindset to have. And that's that we're going to try to do this so safely, the worst outcome you'll have is some numbness and sitting in your back. So I really kind of like that mindset. I think it can kind of help patients feel more comfortable doing this as well. So kind of working on what you're saying and also kind of some goals. We kind of cover this for specifically for erector spinae blocks. You really want to try to aim for, probably about 30 mLs of volume. And when you hit it, particularly like in the thoracic areas, if you're talking about rib fracture or something like that, if you hit 30 mLs, 30 to 40 mLs on that side, you really should be getting 4 ribs above and 4 ribs below when you're trying to hit that mark. So that's kind of your volume. And then you're going to add dexes. These are largely pain control blocks. There's kind of some thought, should we be adding a little bit of lidocaine for a little bit faster onset action? But I don't think that truly matters that much. One great thing about this is, I believe, from like Highland Site. So one great thing about this is the positioning is so variable because all you really need is access to the back. So depending on where the patient is injured or what's the most comfortable position for the patient, you could do the supine, upright, or D cube, and you can really kind of do these. The other thing too is your whole goal is to kind of aim for that transverse process. So you can go cranial-caudal or caudal-cranial, it doesn't really matter. So you can be quite, diverse and really try to optimize your ergonomics to have a successful procedure here. So one other thing here too is, this is actually the same patient. So this is actually trying to decide which probe is better. And you can see on the left side with the linear probe, you can kind of make out a TP there. But with the curvilinear probe, it's actually a little bit easier to see on the curvilinear probe, even though it's at about that. Once you get to about that 4 centimeter mark, that frequency really starts having some follow-up to that lock of penetration. So when we start getting to that 3 to 4 centimeter mark, your curvilinear probe will probably do you better. So this is the same patient. You kind of see the difference there. And the next section is, you want to decide your level. If they have a bunch of rib fractures, you're going to kind of split the difference. So if they're T2 through 8, you're probably going to aim for like 5 or something like that to try to hit those. And then based on, the other area, you try to be hit based on indication. So for a lot of pancreatitis, in a lot of the literature, they've been using T7, for renal colic, T8 or T9. And then we'll give you some more resources kind of that will kind of refer to these. A quick review of your anatomy. So your target is a transverse process. And you can see, as long as you keep control of your needle, you're really not going to be going through anything that you're going to injure to get to it. So, I mean, really, frankly, this is all just like muscle down. So there's really only muscle in between the bone and your probe there. So not a lot of things that you want to hit as long as you keep visualization of your needle. So now that we decided our level, now we want to, sorry, I'm frozen here. Here we go. So this is just showing the kind of the comparison between what you see externally, kind of a graphic from Nisora and then kind of an ultrasound image, kind of to get a sense of what it looks like in those different frames. But once you've decided your level, the next step is to find your level. So if you kind of put it in the, if you took that hemithorax they try to do and you try to put it in mid portion of that hemithorax and you found the rib, if you find the 12th rib and you count up, you just count to the rib that of such desire. This is like counting up to T9 here. So it's good. And you can also go up to the first rib and count down. That's easier, but you're going to count your ribs to find your level. Once you find the rib that you want to do, this is going to be finding the transverse process or finding the nubbin. So you're going to, this is sweeping medial. So rib dives down, dives down, dives down. There's your transverse process. We're gonna do that one more time. Rib dives down as you sweep medial, and there's a transverse process that you're trying to see. So that's your target there. So now you find your nubbin, and now your goal is to come in plane, and you want to lift the muscle belly off that nubbin. So muscle is surrounded in fascia, and you need to get on the other side of that fascia to make this block count. Otherwise, it's just going to be all going on the muscle side of that fascial layer. So you want to get on the underside of that fascia, and you want to lift that up and off that bone. So this is on the blooper reel here. This was a minimally successful block. And you can see here, as you inject, you can see that like those different muscle fibers actually like kind of like splitting apart. So this is not on the underside of that fascial layer. So this was not a great block because of that. Also on the blooper reel, if you see pleura while you're doing this with someone, they are too far lateral. So you're still, this is still a rib. So they need to sweep medial to find that transverse process. So you should not see pleura while you're doing these. And really kind of the standard, I would say at this point to have successful blocks is you really want to try to aim for the corner of that transverse process. It's still your backstop, but if you aim towards a corner, there's kind of some like evolving evidence in terms of, is this actually getting your whole hemithorax? And in some studies, there's kind of like some variable sensory distribution. But really, if you want the most optimal block, you really want to try to aim for the corner. The other thing too is that allows you to get under that fascia a little bit easier. So I may or may not have had one of these done at some point, and the person that did it didn't quite get to that corner, and my entire back was numb, but my side was not numb, and nothing in the anterior portion either. So this is really a kind of a key piece if you want to try to hit their entire hemithorax. And this is just kind of demonstrating that variable sensory kind of coverage when you do these. And really, you're not trying to get a sensory block. For most of these, is really kind of a pain control block. So, I think in general, it's probably better just to assess for pain reduction and not for sensory blockade as a means of whether or not it was a successful block. And then afterwards, don't resist your happy dance because you had fun and you helped your patient. We're gonna go through some different cases, just kind of demonstrate how effective this block has been. This was a person that had some posterior rib fractures, and the person bounced back twice to get the block again. So this person got blocked by our department 3 times because it worked so well. So pretty incredible. And it was great for our residents because some people got to block this person. All right, this is just kind of going through an example of what a rib fracture guideline would look like. If you want to click on that, that's a free resource in terms of like the protocol and kind of guidelines that we've established with our trauma team to kind of facilitate doing these. Another case here, person shows up to the freestanding ED, has a huge UVJ stone. They're pretty miserable. Here you can see that muscle belly being lifted completely up and off that spot. And this person was feeling so good. He went straight from the ER to Texas Roadhouse, and the patient had about 2 days of great pain control. Ended up bouncing back about 4 or 5 days later because of a failed trial passage, but still had a successful pain control with that block. We've been doing a lot of these, and so it is the number of studies, kind of case reports for pancreatitis with rectus blocks is pretty profound. And we've been successfully able to discharge a lot of these people that otherwise may have been admitted for pain control only. I'm not talking about like some sick pancreatitis or one with severe abnormal vital signs or other kind of complication, but those kind of bread and butter pancreatitis that really are only getting admitted for pain control, we've been able to send a lot of these home by facilitating this block, which is pretty incredible. This is usually done with bilateral rectus blocks. So what about a patient that has chronic pelvic pain and endometriosis? So who wants to pick up that chart? It tends to be a little bit of a frustrating experience for the patient because there's not a lot of great options for you to do them. And it's a little bit frustrating for you because you don't have a lot of options to do. And it tends to be kind of like a dissatisfactory encounter. we had this person show up with this exact same scenario, and we said, well, we could try doing a rectus medial block on you. And this person was pretty like in tears. She was so thankful and said that they hadn't felt that good in years. So pretty remarkable in terms of what this block can do for patients. Another kind of example of just some, some visceral relief from that. And so this is a resource that I have developed. So it should literally it should be either like a Google access or Evernote access, but it has a list of high yield notes, all the evidence, including the indications and the level for such, and some other resources. So this is a great resource for you if you want to kind of have that as you're kind of going on shift and getting ready to do one of these. So kind of, and again, big take homes just for rectus sine. You really want to aim for that target, the corner of the transverse process, and you should not see the pleura. And we really need to do more of these because it's a win-win all around. And just some kind of, just for, as kind of doing this at your own chops, there is some evidence to kind of say that this is overall a low risk procedure. And there's also cardiac anesthesia literature showing that this can be done in patients with, anticoagulation and stuff like that. There is I always kind of do this as a relative contraindication, just given that increased risk. And I was going to discuss that with the patient, but I don't think that this is an absolute contraindication where to perform this block. Here are some educational resources, and, I have my slides if you want them, if you don't get any of these. And just kind of going through some free apps here associated just for rectus medial blocks. This top right one, if you don't have this app, you should get it. It is a free app that is designed by Colorado and the Highland folks and the leaders in nerve blocks. And they kind of took all the Highland information in combination with some other resources, and it literally goes through all the different blocks and just gives you those high yield pointers. So this is an incredible resource if you don't have that app yet.